Thanks, Holly. My disclosures. So spinal fusion is something that we all do quite frequently, and this involves something that's non-physiologic. We have to get two segments that move to stop moving and biologically heal. And typically this has involved bone grafting of some kind. So there are many different bone graft materials that exist. There's human allograft, bone extenders, bone graft substitutes, and there's even actually autogenous iliac crest bone graft, which is how I was trained to do this. For bone graft substitutes, not extenders, but substitutes, there's limited high-quality RCT data available to say what is approved. And I'm not sophisticated like Karina, and I didn't use ChatGPT to search all of the possible trials, but these are the ones that I know of. Payer coverage. This is something we all have to live with. In the past, bone graft material or substitutes, the payers didn't really care, but that has changed, and it's changed payer by payer and state by state. In my state, in Minnesota, we had payers who said, if you use something that we don't approve, we will deny the entire episode of care, not just the bone graft, the entire episode of care. So our hospitals kind of clamped down on us about using things that were not approved by the payers. So what do payers and the most aggressive payers look at? Is there high-quality human data? Is it FDA approved? Is it being used in an on-label fashion? And just to point out, minimally manipulated human tissue is not FDA regulated. And then there's been some discussion about price points, and this has been variable as well. So what is the process for approval of a bone graft substitute? The answer is it's got to be FDA approved, and in the past that was enough. It's not anymore. Now it has to be used on label, and is there high quality human data with at least 2-year follow-up? So what does it take to get the payers to do this? Well, unfortunately, so first you have to get the data. Once you get the data, then you get to go payer by payer to ask them to cover it. Typically, this is done by starting with CMS, and there's not a single CMS decision. CMS has regional medical administrative contractors who make local coverage decisions, and that they determine which services are reasonable and necessary. And these are the list of the current MACs that are present. And if anybody's here from Wisconsin, I find it entertaining that Wisconsin Physician Services is not actually the Wisconsin MAC administrator. Medicare Advantage. I tell my patients now, I call this Medicare disadvantage, and that they are not subject to the coverage determinations done by Medicare. This reverts back to what is their particular payer coverage determination, like is it United Healthcare. So commercial payers make their own rules as they see fit. They have varying levels of evidence requirement, and they often call things experimental if they don't want to pay for them. And there is a little bit of herd mentality. If the bigger payers choose to cover it, the other payers tend to eventually follow suit. And when they say, well, it's not a covered benefit, what is their argument about standard of care? And they say, well, we're not telling you how to practice medicine. We're only telling you what we will pay for. And this is not about the best practice of medicine. It's about a contract benefit. And that's how they dodge any sort of liability. So Lou Tumialan told me, he said, every talk I want one takeaway from it. So this is the one takeaway. So BMP has now been approved for TLIF. And so that if you take a screenshot of this and put it in your note, maybe they won't say it's experimental, and maybe this will help you with coverage determination from your particular payers. So what do we have to do as a professional medical association to go forward? So we've got FDA approval. Now it's payer by payer, state by state, asking them to initiate coverage. There are some tricks to this game that companies like Blue Cross Blue Shield have evidence councils that generate something, but each Blue Cross Blue Shield is free to follow or not follow that recommendation. And that it's our job now to see if we can get this moved forward to enable us to be able to provide optimal care for our patients whatever device or substitute for bone graft material it is that you're looking forward to use. And this is a long process, but it takes societies like this and leadership to take the lead, and it's a long slog, but it's the right thing to do. So thank you very much for your time.